Good morning, everyone. Welcome to Distinguishing NMOSD from MS. Today, we are going to learn a little bit about both conditions and go over some key differences to help build clarity and awareness and hopefully improve your patient experience for either yourself or others. We're going to hear from an expert in the field as well as two patient advocates, and we're going to go over a few housekeeping rules, and then we'll get started. Okay, let's make online gathering as smooth and enjoyable as possible. Here are some digital healthkeeping rules. Participate actively, engage, ask questions, see the little chat function. At some point, I might ask you to drop some emojis in the chat just to keep things fun. Use the chat wisely, and if you're having any tech troubles, just kind of signal us in the chat and we'll try to get you some help as soon as possible. And first up, with a very, very familiar face to the We Are Ill community, we'll be hearing from board certified neurologist, Dr. Mitzi Joi Williams. Please help me welcoming Dr. Mitzi with clapping hand emojis in the chat.
Hello. Happy Saturday, everybody. I'm Dr. Mitzi and super excited to be here with my friends from We Are Ill and also with Victoria and Sumaira. I know this is going to be an amazing program. So I appreciate you guys asking me to be a part of it, and let's get right into it. Okay, so first we're going to start by setting up and talking about some of the key terms, right? So we are going to be talking and focusing primarily on NMOSD, Neuromyelitis Optica Spectrum Disorder, which we'll talk in a little bit more detail about what that means and how we distinguish it from multiple sclerosis. When we talk about these diseases, they are both autoimmune disorders, meaning the immune system, the part of the body that normally attacks viruses and bacteria, gets confused and attacks a good part of the body. And they are also diseases that affect the central nervous system, which includes the brain, the spinal cord, and the optic nerves, or the nerves to the eye. One of the blood tests that specifically helps diagnose NMOSD is called aquaporin 4 antibody. And so these are antibodies that are really the target, that tell us about the target of what's being affected in the central nervous system in those who have NMOSD. All right, so first let's back up. Let's talk about what is MS, because oftentimes people are much more familiar with MS than they are with NMOSD. And also, a large percentage of people with NMOSD have and are misdiagnosed with multiple sclerosis. So, the main hallmarks of multiple sclerosis are that it is a central nervous system disease, it is progressive, it's also an autoimmune disease, but it primarily affects the brain and the spinal cord. Some of the symptoms are very similar and overlap with those with NMOSD, including weakness, numbness, and tingling. Some people may have vision changes, optic neuritis, which we'll talk in a little bit more detail about later, and then other issues like cognitive problems or even fatigue. So where does NMOSD fit into this? So I'm, a little seasoned in this. I've been doing this for a while. And so when I first started practicing neurology, it was at a time when NMOSD was considered a part or subtype of multiple sclerosis. So we've known about NMOSD for many, many years, almost as long as we've known about MS, but it used to be considered a part of MS, and now we know it is a distinct disease. So there were studies of MS, what we called MS in Asia, and they found that there was more involvement of the spinal cord. So people had more weakness and numbness, as well as the vision, than with MS, and it also seemed to have more severe progression. So this was first described in the 1890s, right? And we know MS was first described in the 1860s. And it was, I'm not going to try to pronounce that name or what they called it, but that's how we got neuromyelitis optica, was from that very interesting name there. And then it was thought to be one disease and part of MS, but as I said, eventually we came to realize that this was a distinct disease from MS. Okay, so when we think about a little bit of a timeline, right, of how this was discovered, so 1894, we knew that there were some forms of demyelinating disease where it was affecting more of the spinal cord and the vision, didn't look like typical MS, but was thought to be a part of MS. And then this is just kind of a timeline of, you know, understanding the antibody for NMOSD. So in 2002, there was thought to be a protein that was identified as the culprit for what's being attacked in NMO. And then in 2004, the antibody was found. And then in 2005, we had a name for the antibody, which is the aquaporin 4 antibody. And this antibody, or sorry, is an antibody to a water channel that's very widely expressed or is present in the optic nerves, the spinal cord, and also certain parts of the brain. So this is just kind of a visual graphic because I like pictures. And so we can see 1894, we heard about this NMO. We used to call it DeVick's disease after Dr. DeVick. And then really there was nothing much going on after 1894 because it was considered part of MS until 2004. And that's when things really started cooking. So 2004, the antibody was discovered. By 2006, there was diagnostic criteria to distinguish NMO from MS. And then by 2007, we had this, what we call spectrum of disease, where people maybe didn't have visual and spinal cord problems, but one or the other, and maybe the antibody. And then again, from 2017, there was nothing really going on to 2019 when we had the first FDA approved treatment for NMOSD. So it's really recent that we now have medications that are FDA approved for this condition. And there are, I believe, three or four treatments now. Okay, so again, this is a disease we thought was part of MS. We realized that it was actually a distinct and different disease from MS, and that the MRI lesions that we saw were different than what was seen with MS. And so this became separated as a distinct clinical syndrome outside of MS and is no longer considered part of multiple sclerosis. All right, so when we think about kind of what distinguishes it from MS, because a large percentage of those who have NMOSD have in the, past 20, 30 years or so been misdiagnosed with MS. So what kind of distinguishes it clinically? So oftentimes when we think of optic neuritis or vision problems with MS, oftentimes people have one-sided vision loss. So people will say, hey, Dr. Mitzi, I lost vision in my right eye. More commonly with NMOSD, people can have one-sided vision loss, but it often is very severe. And then they also will more often have both eyes affected at the same time. Sometimes there is more severe involvement of the brainstem or the bottom part of the brain, which can control some of our automatic functions like breathing, etc. And then people will have long lesions in the spinal cord. So the lesions in the spinal cord that we see on MRI look different in NMOSD than they do with MS. And oftentimes, if there are lesions in the brain, sometimes the brain will be completely normal, but if there are lesions in the brain, they actually are very large and sometimes can be mistaken for tumors. So we used to also call, before we distinguish NMOSD as a disease, we used to call it tumefactive MS, meaning you had a big spot that looked like a tumor and led to many people having brain biopsies because we were concerned they had cancer, but they actually had demyelinating disease. And then, of course, there's this antibody that we talked about, the aquaporin 4 antibody, which is a simple blood test that can be done to determine if someone fits more into a category of NMO versus MS. All right, so what do we know about the disease in general? Who does it affect, right? So it definitely has a predominance for women. So most autoimmune diseases are more common in women than men. But this one is about 80 to 90% more common in women. So with MS, we think of a ratio of 3-to-1 affecting women to men. With NMOSD, we're talking more 8-to-1 women to men, okay? There is no difference in the gender when children are affected. The age of onset is usually 35 to 45, so a little bit older than what we think of with MS. About 20% are children that are affected, and then about 80% have that positive antibody. But again, everybody does not necessarily have that positive antibody. What we also know is that this particular condition tends to affect Asian populations more and also Black populations more as well. So the prevalence is about 10 per 100,000, which is much less than we see with MS. The incidence is about 0.2 to 4 per million. Again, it's a predilection, so people who are of various ethnic backgrounds are more likely affected than people we would consider white or of Northern European ancestry. And those who are of varied ethnic backgrounds, including those who are Asian as well as Black, or of African descent, seem to have more brain attacks, which can be more severe. So let's get a little bit more into the nitty gritty of some of the symptoms, right? So transverse myelitis is one of the hallmark symptoms that we see with NMOSD. And transverse myelitis basically means you have a lesion in your spinal cord that causes damage. It doesn't tell us what it's from. Transverse myelitis can happen with MS. Transverse myelitis can also happen with NMOSD. But what we see with NMOSD is that people may often have more severe symptoms. And they also have the lesions we call longitudinally extensive. So they're long. Whereas with MS, you have short lesions, so you have a little dot here, a little dot there, but it's not like one long spot or one long area of damage affecting the spinal cord. And so the symptoms that we can see can be weakness, they could be numbness and tingling, people can have spasms. Again, more often than not, the symptoms can be more severe. So someone may have paralysis where a limb or extremity doesn't move at all. And so most of the lesions, as we said on the bottom, over 50% are longitudinally extensive lesions in the spinal cord. And so this is the type of transverse myelitis that we see with NMOSD. So what about optic neuritis? Again, this is a symptom that we see with MS. Some people can have optic neuritis and not have any other symptoms of demyelinating disease, but certainly this is one that raises concern. And optic neuritis, we can see the comparison between NMOSD and MS. Certainly people can have vision loss. Sometimes they can have decreased color vision. Sometimes they can have spots in their vision, but we more often see blindness with NMOSD. So there may be more severe vision loss, and there also may be poorer recovery. And then also we talked about earlier that people more often have bilateral or both eyes affected with optic neuritis in NMOSD than they may have with MS. So then again, other parts of the brain that are affected. So classically, when we think of NMOSD, we think that there's not much brain involvement, but we do know that there can be specific syndromes or areas that are involved. One of them is an area we call the area postrema. I have no idea how I got that name, but the symptoms of that area being involved are things like hiccups, intractable hiccups, nausea, and vomiting. And so I have had multiple patients who've gone to the ER for nausea and vomiting that won't go away and been thought to have a stomach symptom, but really it was due to a lesion in the brain because they had NMOSD. So again, there are specific syndromes that we can see in the brain and brain stem that are more typical of NMOSD. We don't typically see that syndrome as much with multiple sclerosis. So why is it important, to treat this disease? I think number one, it's important to treat it because it is a demyelinating disease and it's affecting the central nervous system, but particularly because the outcomes from a relapse can be extremely devastating. With MS, certainly relapses can be devastating, but we see recovery a lot more often with MS relapses versus NMOSD. And so it's important to have a comprehensive care team. So looking at your neurologist, who is the primary kind of leader, head cheerleader of your team, directing treatment, and then certainly a primary care physician to do screening and checking for all of those, regular things. We saw the ages were 35 to 45. So that's around the time women start getting mammograms and all that good stuff. Also, it's important to have other specialists depending on what symptoms are involved, physical therapists, mental health specialists as well. So comprehensive care is key to good outcomes for those living with both MS and NMOSD. So when we think about treatment, I always like to think of treatment as a 4-layer cake because I like cake. So the first layer is certainly if someone has an acute relapse or episode. So an acute relapse or episode, it initially is treated very similarly to what we would do with multiple sclerosis. So a person can be treated with IV corticosteroids or high dose steroids. Sometimes if people don't respond to that, there is another procedure called plasma exchange that can be done. It's almost like dialysis. Yes, I like cake. I saw cake for Dr. Mitzi. Yes. It is almost like a dialysis that can be done to kind of wash the antibodies out. And then sometimes there are other treatments like IVIG, which used to be used very commonly for MS, but still can be used for NMOSD. It also is important to recognize that some of the treatments, the disease modifying treatments for multiple sclerosis, can worsen NMOSD. So that's why an accurate diagnosis is extremely important, because we don't want to give you something that's going to make your NMOSD worse. I'm not going to go into detail about each of these, but again, important to recognize that there are now several FDA approved treatments for NMOSD, and we have come a long way. So this is just 2019, right? Where the first one was approved right before the pandemic. So again, we have a disease we recognized in 1894 that became a distinct disease in 2002. And then it wasn't until 2019 that there were actually medications that were approved to treat this. So again, very exciting. We have a long way to go, but I think we also have come a long way in being able to treat this particularly very disabling condition. So what now? There certainly is still a lot of work that needs to be done looking at NMOSD in underrepresented communities. So although the disease more commonly affects Asian populations and Black populations, when we look at the research is often done on European populations, right? So there's still a lot of work to do to better understand how this affects certain communities as well as the burden of disease. It also is important for us to make sure we raise awareness in the community so people are aware of these symptoms, so that they can get adequately treated and appropriately diagnosed. And of course, I'm always an advocate for increasing diversity in clinical trials, and we need more people of varied backgrounds in our clinical research to really understand this condition and to help us to treat it effectively for everyone. And with that, I am done, and I am going to hand it back over to our host, who will bring up Victoria, who's our next speaker. Or do I have time for questions? Okay, so I think we have one question that I should be able to answer. While distinctly different conditions, is it possible to have both NMOSD and MS, or would it be more likely to be considered an atypical presentation of one or the other? Yeah, so it's probably going to be one or the other, right? Because we do have an identified target with NMOSD, and it does have certain clinical characteristics. And just from it being considered a part of MS for so long and us realizing that it doesn't really respond as well to MS treatments, most people would fit into one category or another. So thank you so much for that question. We'll come back at the end for more questions, and I will hand it back over to our host.
Thank you so much for that, Dr. Mitzi. That was extremely helpful. For our first, and if you guys have any more questions, you can still leave them in the QA, and hopefully towards the end, we can kind of circle back to those. So for our first patient advocate, we have Sumaira Ahmed. Sumaira is the executive director for the Sumaira Foundation and an NMOSD advocate. Please join me in welcoming Sumaira with flower emojis in the chat.
That's nice. Hi, everyone. Happy Saturday. Happy summer. Thank you, We Are Ill, for inviting me to this lovely program. One of the best parts about what I do is I get to meet so many incredible patients, caregivers, people, and advocates from all over. I have a lot of respect for Dr. Mitzi, of course, and Victoria. So thank you all for having me today. My name is Sumaira, and I am first and foremost a patient living with neuromyelitis optica spectrum disorder. I was diagnosed 10 years ago, so I will be celebrating my NMOversary this summer. And I'm also the founder and executive director of the Sumaira Foundation, which I will tell you all about today. But I think it's always very important to start with some history and how did all of this happen? So here you have a collage of photos. These photos were from 10 years ago, so I have aged. It's apparent, but I was diagnosed with NMO in August 2014, just 5 short weeks after I experienced my first symptoms. So I was perfectly healthy, very, very fit. I was a dancer my whole life, pretty much. And one day I woke up and I couldn't see out of my right eye. And as many of you have experienced, it's incredibly terrifying and devastating. But, you know, I happened to be at the right place at the right time. I was working in ophthalmology at that time for several years. And so, thankfully, because of my access to eye doctors, I was able to be evaluated almost right away. And basically the after I lost vision in my right eye, the first episode, I was sent for an MRI. And as Dr. Mitzi explained, with MRIs for NMOSD, you'll oftentimes find inflammation of the optic nerves and the spinal cord. And so my first visit my first episode, I was diagnosed with idiopathic optic neuritis, and I was told I had a 16% chance of developing MS at some point in my life. 5 weeks later, I had a second episode, which was far worse than the first episode. And that's when I lost vision in both my eyes and I couldn't feel the entire left side of my body. And it was after that episode where the doctors had deemed that I have neuromyelitis optica. And what's maybe more challenging is that I'm seronegative, which means I do not test positive for the antibody even 10 years later. So we can advance to the next slide. And obviously, getting sick at any age is so devastating, but I think getting sick when you're so young and it kind of happens out of nowhere with any warning, it can really shake your entire world. So I was depressed, I was sad, I was scared, I was angry at my own body. Why did I get diagnosed with something that no one had heard of? So rare. Did I do something to cause this? And then a close friend of mine sent me this quote that kind of changed everything for me. So the quote is by R.M. Drake, and it reads, "There was a flower in her heart. It just needed more room to bloom. And when she let it free, she showed the world that sometimes the most beautiful things can grow in the darkest of places without the need of light." This resonated for me on so many different levels. The first is, I lost my vision. So I felt very much in the dark, literally and figuratively. And also, Flower is my nickname. It has been for 20 years. So people call me Sumaira Flower. They call me Flower. So I just read this and I know why he sent it to me. And then it gave me this idea. Next slide. That I needed to do something about this. I did not want to die because no one knew about NMO, and I didn't want others who were living with this or whose family members were living with this to be suffering in silence or without a platform or a support system or a community. Just for some background, I was in the entertainment industry for many years of my life, pretty much from the age of 3 to 24. And then I studied public relations in university, and then I started working in healthcare. So when all of this happened to me and the wheels started turning, I said, hold on a second. I've got these incredible elements that when you piece them together, maybe I could do something for this community, even if it's small, even if it helps one other person. I wanted to do something. So within a month of my diagnosis, I decided that I was going to go down this path of advocacy, something I had never done before. And so this is an article from the Boston Magazine that announced that I was going to be launching the Sumaira Foundation. And so here we are. We are dedicated to illuminating the darkness of NMOSD and MOGAD and now getting into other rare neuroimmune conditions. We were established in 2014, which means in addition to me celebrating my 10-year NMOversary, we are celebrating 10 years of the foundation this year. We have 4 pillars: awareness, community, advocacy, and research. And I love to share that we are patient-led, patient-powered, science-driven, and therapy agnostic. I also love colors. I think that's pretty obvious. Here is a picture from a lot of us advocates, including some ambassadors from the foundation, on Capitol Hill last year, where we advocated for more funding for rare disease research and advocacy. I should also share that diversity is a superpower for our foundation. I personally believe in diversity. I think it's one of the most beautiful parts of being a human, that there are so many different kinds of people who are from all walks of life. And when you have something that bounds you together, it's amazing what can be done. So on the topic of ambassadors, we have 75 ambassadors from 25 countries around the world. And these are patients, caregivers, and clinicians. We have made our website available in 25 languages because, let's be honest, science is not for everyone. It's not for me. 10 years later, I still have trouble understanding some of these very difficult jargons that surround our diseases. So we've tried our best to make our website A, very in layperson's terms, and B, in so many different languages so that people can understand all of this very difficult information in their native language. So next slide. Next slide, please. Oh, this is the last slide. Oh my gosh, sorry. I didn't realize that. Okay. So anyway, that's just a little summary about the foundation. You can follow me on social media as well as the foundation. As I said, we're very colorful. We're very much about, I would say, very, very patient-centric. Obviously, I'm a patient myself, but we work with a lot of contractors who are patients. So, as I'm not perfect and the foundation is not perfect, but one thing that I have really set my mind to and my heart to is doing whatever I can in my very limited capacity to empower patients, caregivers, and clinicians all over the world. And I will just say that as patients, we have a lot more power than sometimes we think. And that can be, using our voices to elevate the awareness of our diseases, to advocate, like in these pictures, on, to different levels of government, and also, even in research. So as a patient-led foundation, we have donated almost $1 million to research in the last 5 years. For me, this is a very big number. I could have never imagined in my wildest dreams that we'd be able to do that. But we also encourage patients to enroll in clinical trials and to be part of the process in understanding our diseases and advancing the understanding of our diseases. So anyway, all this to say that I'm very happy to be on this side of the equation where we can really see the fruits of our labor and do something for our diseases, even when sometimes it feels like we can't do anything. So on that note, I will pause. If anyone has any questions, by all means, feel free to ask. I think I have a few minutes left, but if you don't, thank you for listening to my short story, and please visit our website. Maybe one of the show hosts can put it in the chat. Our website is sumairafoundation.org. You can learn all about the foundation, the ambassadors, support groups, research about our diseases, and again, in 25 languages, which I think is super important. So thank you so much.
Thank you so much for sharing your story, Sumaira. The slides are great to see. And thank you, Angela, for putting the URL website in the chat. So next up, we have, of course, We Are Ill's very own founder and CEO, Victoria Reese, who will also be serving as the MS advocate today. Please join me in welcoming Victoria with star emojis in the chat.
Yes, I love a star emoji. I'm happy to be here, and thanks for everyone for joining. I know it's summer, I know it's hot outside, and you can be anywhere, but you chose to be here. So thank you for joining us. Next slide. So before I get into my story, as mentioned, I'm the founder of We Are Ill, and I'm a person living with MS. The year was 2012, and in January, I moved to Los Angeles, California to start my career. And May 2012, I turned 25 and I was living my very best life. As you can see, I was taking pictures with the Hollywood sign, just living my life. My hair was blonde. I was living my life. Um, by July, I began experiencing numbness and tingling in my legs over the course of several months. I had no idea what it was. I didn't understand why my feet and legs felt like they were falling asleep. And I didn't go to the doctor immediately. I tried to kind of push through, thug it out, because I didn't really have the time. By September, I was actually diagnosed with MS. Next slide. So I use this image. It's not funny, but it is kind of funny. This is from Wolf of Wall Street. And I say this is actual footage of me getting in the car, because there was times where on my way to my car in the parking structure of my job, my legs would go completely numb and I had to crawl to my car. And it's funny now, I could joke in this safe space, but it was very traumatic and very scary and very embarrassing at the same time. Next slide. So a little bit about my diagnosis. So I was experiencing that numbness and tingling over the course of a few months. And I finally went to go see my primary care physician, because at 25, that's the only doctor that I had. So I go to my primary care physician, and we were in Beverly Hills, California. At the time, that's where I worked, and that's where my doctor was. And I told him that what I was experiencing, numbness and tingling. And I didn't say numbness and tingling. I just kept saying my legs are falling asleep. My legs are falling asleep. And that it will come and go, come and go. And I told him, like, I stopped wearing heels. And, I'm sad, but I stopped wearing heels. And if that's what I got to do, that's fine. But I need to figure out what's going on. So he had me get an MRI on my legs. And that was my very first MRI. And when he got the MRI results back, he called me and he thought I was crazy. He's like, there's nothing going on with your legs. The MRI would show me everything, and there's nothing going on with your legs. So I'm like, well, doc, if you don't see anything and you think nothing's wrong with me, then I don't know what it is. And of course, he thought I was crazy. And so he started to ask me, I was letting him know, like, this is really scary for me. I don't it's not nothing. It's got to be something. So he started to, I guess, do more of an investigation of who I was and my lifestyle. So I told him I work down the street. I'm a Hollywood assistant at a talent agency. I'm really stressed at work. It's very fast paced. He's like, oh, you're one of those assistants. Okay. I know the life that you live. I know how the job is. You're stressed and you're depressed. And I'm like, okay, I am, but I've been stressed and depressed before, and it don't make my legs go numb. So this is weird. He kind of forced it on me, but said, you're depressed. I'm going to prescribe you antidepressants. And he prescribed me antidepressants, and I went on my way. Well, little did we know, I kept having more episodes of the numbness and tingling in my legs. And they kept coming back. And I just was taking those antidepressants, thinking that was the only thing going on, because doctors know best, right? So it kept happening. And one day I had this really excruciating migraine, and I didn't get migraines ever, really. And it lasted for like 10 hours. It was really terrible. Couldn't drive, couldn't really function. And I went to that same doctor, and I woke up that next day, and I had numbness and tingling on my face. So then I thought I had a stroke. So I called the doctor, and I'm like, I'm seeing some similarities here. It's numbness also in my face now, not just in my legs, but in my face. And it was just on one side. So he called me back in. I get another MRI, but this time on my brain and my spine. The MRI results come back with 9 lesions on my brain. And now my doctor is confident that this is probably MS, because the numbness and tingling and the lesions. He told me that Black people don't get MS. And he printed out a few pieces of paper of like a WebMD definition of what MS was, stapled it together, gave it to me, and sent me on my way to learn about my new normal. And that was the day I got diagnosed. And that was September 2012. 12 years ago, almost 12 years ago, that I got diagnosed. And I was really afraid. I couldn't read like the pages of the definition of what MS was. I couldn't read that for like 6 months because it would make me sick to my stomach because I wasn't really ready to accept that I had this diagnosis. And of course, being the millennial I am, I was Googling it and the worst things came up. Next slide. So this slide kind of talks about, what I already mentioned about how he was confident that what ultimately was MS was me being stressed. And I want to acknowledge that I felt that racial bias took place. He asked me where I was from. He asked me what I was doing in LA. He asked me what I did for a living. He asked me what I did socially. I do understand that doctors ask these things to understand how it may affect your health. But I felt that he was just trying to figure out why this Black girl from Detroit was in his office. And he did not believe me, even though I was interested in seeking more testing. So next slide. So seeking support is not like natural to me. It's funny because I have a patient advocacy group now, but seeking support wasn't innate to me. I'm from Detroit. I'm born and raised there from a single Black mom, and we don't do therapy. And that was what I thought at the time. We don't do therapy. We don't do support groups. We don't do no societies. And we don't do anything else that is telling people our business or asking for help. It's definitely letting people know that something could be wrong. We don't do that in quotes. And I know that the Black community, we're not monolith by any means, but I do know that we are just now kind of jumping on board with mental health and seeking therapy and removing the stigma that comes with it. So I didn't seek any of that when I got this diagnosis of an incurable disease at 25. I had just moved 3,000 miles away from my family, and I was dealing with this by myself in LA. So, like a true millennial, as I mentioned, I went to the internet to kind of use it as my digital diary to tell people like what was going on. I was like, look, if I gotta get poked and prodded and I gotta be in this new world, which I didn't know what direction it was gonna take me, I was like, my followers are gonna come with me. And at the time, it was just like my friends and my family that were my Instagram followers. Instagram was fairly new at this time. People were still using it just for filters. Long story short, I started to tell people about my experience when I got a nurse. And a nurse came to my house and tried to teach me how to inject myself, all the things. You can, stay on this slide really quick. This is the first picture that I posted when I came out or announced that I had MS. I said, like, F it, I can't hold it anymore. My name is Victoria and I have MS. And it was just my way of, I don't know. It was my own therapy where I felt liberated and free because nobody knew and nobody was going to be there with me to help me experience this. So I'm like, let me just tell people. I felt like if I got ahead of it, no one could use it against me. Next slide. So a few years passed. As mentioned, I got diagnosed in 2012. It took me a while to meet another Black person that had MS. It took me 4 years to meet another Black person with MS. And during those years, I was actively going out, raising my hand, trying to go to different events in the community. I went to support groups. I only went to support group once, but I went to different fundraising events, MS related events. And every time I went, I'm like, where are the Black people? Where are the Black people? Or where are the millennials? Like, where are like the young people? Like, is nobody 20? I know I can't be the only 20-year-old Black girl that has MS. But in general, I also was saying, where are the patients? When you go to some events, it's fundraising events. So it's a lot of people whose cousin or aunt had MS and they're raising funds. But I was like, where are the patients? I want to meet other people with MS. Like, we could talk about MS things. So I was looking for that and I couldn't find it anywhere. So I realized that I need to somewhat create it. In 2017, I launched a digital awareness campaign on Instagram because we know I like Instagram. I started a digital awareness campaign called #WeAreIllmatic. And yes, the Illmatic aspect of it is in a reference to Nas' first album, Illmatic. I got the Illmatic from him because I think that year, it might have been an anniversary year or something, or the anniversary month of when it came out. And I was scrolling on Instagram and I saw the album cover and I knew Illmatic, but I never thought sick. I never thought ill. I thought like cool ill, dope ill, but I never thought sick until I was ill, until I was sick. And I was like, you know what? I'm that kind of ill too. Like I'm sick, but I'm lit. Like I'm sick, but I'm cool too. And I don't want to ever remove that from who I am. So let me rephrase or repurpose this same word, illmatic, and say, like, when you get sick, you can still be the same person, or you can still be all the things. So I did that, and on the first day that I posted it, Nas actually reposted it to his followers, 3.5 million followers. And I want to say the rest is history, but it's not. More came. In the comment section of that post, all the people were saying, Nas, like, who are these Black girls? Or I've had MS for 20 years and I've never met another Black person with MS. Or my family doesn't even know I have MS. I haven't told anybody. And I think I started to see that I wasn't the only one that was looking for community, looking for myself in this space. So by 2020, I realized we need to be a nonprofit and we need to be a patient advocacy organization. And that's when I launched We Are Ill. I had to remove and separate myself from Illmatic. And so We Are Illmatic has a vision to redefine what sick looks like for Black women living with MS. Our goal is to build a fearless community and create culturally competent educational materials. There's educational materials, and then there's culturally competent educational materials. And my rule is, if you're talking to everyone, you're talking to no one. So when it comes, similar to Sumaira, when we use, we make sure we use our branding, we want to make sure we are consistent and we use colors of melanin and hues of color and colors that identify and resonate with our community. So browns and maroons, mahoganies and creams and neutrals. By facilitating these experiences for Black women, we want to change the narrative of MS to not only improve overall health outcomes of Black women, but to eradicate this disease. And these pictures on the right side are pictures from the very first photo shoot from the campaign that I did. I think I saw Dania in the chat earlier, but I was in LA at the time. I found some Black girls that had MS, and we did a photo shoot to promote what this is. Next slide. So where we are now, Black women with MS, we still need a lot of things. And similar to what the Sumaira Foundation is doing is we're building community. It's a safe space to just learn from each other, feel inspired from each other, but just to remind yourself you're not alone. These illnesses are unique, very unique. And because because it hits us all differently, because we all experience it differently, it's just nice to have that through line with people. I don't care if my MS looks different from your MS, but us having MS at the same time, we are sisters regardless. And there's a bond there. And I love that bond and that sisterhood. Next slide. Collecting people. I've used these slides before, and a few people are like, collecting people sounds like you're a serial killer. I'm not collecting people literally, but this is just a term I use when I say that, when I go to a room with people living with MS, I want them to remember my name, remember my story, but remember the story of Black people and Black women that live with MS, and don't forget that Black women have MS. And so when I say collecting people, I've collected people like Brianna, who just, introduce us. I've collected Dr. Mitzi on the way in this patient advocacy work, and I've collected Sumaira along this journey. And that has been the best thing ever, because it has truly improved I believe my health outcomes, because I'm more knowledgeable. I'm more aware of what's going on. I'm in a network of amazing healthcare providers. If I have any questions, I may not even need to ask my doctor, Dr. Mitzi is my doctor, but I may not even have to ask her. I might learn from a panel because I've learned from, the other healthcare providers in the network. That is what has been truly a game changer for my health, is being in the networks, staying a student, and always trying to learn and stay updated on what's going on. Next slide. All right, so I'm running out of time, and I've got a 4-year-old birthday party to go to, but right now, I think it's very important that if you're on this call today, I believe that you understand the importance of self-advocacy, and health literacy and self-management. You believe in being the best patient that you can be. And we know that we can only be the best patient that we could be if we're being honest about the patient that we really are. So, are we taking our medications? Are we listening to our bodies? And are we tracking changes? So make sure you have integrity. And that's what I call a professional patient. Next slide. All right, this is my last slide, guys, so then I gotta go, because I wanna make sure we have some time for questions. This is our wellness weekend. We Are Ill. We have an annual patient conference. And very much like Sumaira mentioned, we are also a very patient-centered organization and community. We are patient-ran. Our team is full of Black women living with MS. We've got a few support partners, but we, to the core, believe in putting the patient first and the patient at the center of their health. So this annual conference is amazing. I created this because I wanted to see this. I was looking for this when I got diagnosed, and it just simply didn't exist. So we gather in Atlanta annually to join and convene and fellowship and dance and have fun, but also learn. So tickets are on sale now. You can go to our website. I'm sure you know our website because you're here today, but we also have a very dedicated website. If we could put that in the chat, it's wearewellnessweekend.com, and tickets sell out every year. And I want to make sure that I acknowledge that you don't have to be an MS patient. You can be an NMO patient, and attend and still learn valuable information. It is not very much so science information. It is very much so wellness information and patient education, so everyone can learn. You could have diabetes and come, and you will still leave and learn a lot from this conference. So thank you all for joining. Thank you for listening to me blab about my story that I feel like I've told a million times. And now I'll leave it open for questions and group discussions. Thank you all.
Thank you, Victoria. I can't wait to I don't know if I'm going to use collecting people against you, or you're one of those people. No, I'm joking. But thank you for sharing your story. We're going to wrap it up with a group discussion. So I'll turn it back over to Dr. Mitzi. And this is a great time to keep entering those questions or comments or emojis in the chat. Thank you.
All right. Thank you so much. And I'm going to invite Sumaira back up as well. We have time just for a couple of questions, but I think there was one question that was left over from when you were giving your portion of the talk, and thank you so much for sharing your story, Sumaira. It said that when your vision is lost, does it ever return even slightly? So tell us a little bit about your experience, and then we can go from there.
Sure. So 2 things. So the first is I want to make sure we understand the difference between visual field loss and then actual like acuity. So what happened to me in the beginning, my first episode, was that I lost field of vision. So I couldn't see in my right eye, like 70% was gone. But whatever was left out of that little 30%, I still had 20/20 vision. So that was episode 1. A few weeks later, my second episode, I lost about 75% field of vision in both of my eyes, and my acuity went from 20/20 in both eyes to 21/20 in my right eye and 2600 in my left eye. So that means that I couldn't even identify the E on the Snellen chart at the eye doctor's office. Thankfully, because of almost immediate intervention with IV steroids, I've had plasmapheresis twice, and then they started me on immunosuppressive therapy. I was able to regain a lot of my vision back, but I would say 10 years later, I have a permanent like field loss of 40% in my right eye. My left eye has fully recovered, and I'm about 20/40 in both of my eyes. So that's where I am now. It is possible to get vision back. I think it depends on your situation and how early, you know, there is treatment intervention. So I consider myself lucky, even though I still have, you know, vision loss, but I'm able to sort of navigate my life perfectly fine now.
Yeah, thank you so much for answering that, and the honest answer is that for many people it's variable, right? Just like every person with NMOSD, every person with MS is different. The level of recovery is different, but I think the key is what you said, early intervention. You got checked out, somebody got you treated, and that certainly can make a big difference. And I think we really have time for one more question. So I'll kind of wrap this question into some of the other group questions we had. But as a person that's asking about, they live in a little bit outside of the city of Atlanta, and they were asking about maintaining awareness and self-help groups. So let's kind of frame this in, how do you advocate or make raise awareness in your local community? Let's say if you don't live in a big city and maybe don't have access to go to all of the events that are going on in the city, what would your suggestion be for that, Sumaira?
There's a lot of virtual meetings too, and I know it's not the same as in person, but because of organizations like We Are Ill and TSF, and even Joy Life is doing a lot of work on this front, I would say take advantage of these virtual opportunities, and you never know what that can turn into. We've seen so many situations where we create these Facebook groups for local communities, or, you know, have these support group meetings, and then people find out that they only live a couple of blocks away from each other. So even if you can't make it to, let's say, an event that's an hour and a half away, there may be a patient near you and you just don't know it. So my advice would be engage as much as you can and as much as you want. It isn't for everybody, but you may be surprised to learn how many more people are around you with this, just kind of living in silence about it.
Absolutely. And I would say, I always say if there's a need for something in your area, you just may be the person to fill that need, So going to programs, there are all kind of programs that do go on in local areas, whether they're with companies or other places. Other organizations, that is a way to meet people locally. And I found that when I give a talk in whatever part of the city, Savannah or whatever, those folks get to know each other and they do their own thing, so that could be a great way to start your own group and to stay connected to people who live locally, because everybody needs that local support as well as the larger organizations that are doing things in the city. So I think that's all the questions we have time for. So I am going to hand it back over to Brianna to close us out.
Okay, yes, that concludes our program. Thank you all so much for joining us today. Our community is everything, and we appreciate how much you guys engage. Thank you to Dr. Mitzi and Sumaira and Victoria. We hope you guys found this information helpful and hopefully leave feeling inspired. And last but not least, thanks, a huge shout out to our sponsor Amgen for making this program possible. So have a great Saturday, and we will see you guys soon. Bye. Thank you. Thank you.